So now I think things are less confusing for me. We'll go ahead with the panel discussion. The topic which is given to me, which is falling in line with the theme of this meeting, is non-operative management of carcinoma esophagus after CTRT response. We all know that rectal cancer treatment somehow is being followed by the esophageal cancer treatment. For example, the importance of radiation, neoadjuvant treatment. In rectal cancer, we have German trial. Then, same in esophageal cancer, we have the Dutch trial, which reiterated the importance of giving a neoadjuvant CTRT followed by surgery. Now, in rectal cancer, we have moved on to the next phase, where we are going to go ahead with only CTRT and no surgery. I'm sure that with the advancements of the other surgical specialties as well, we are also going to reach that in esophageal cancer. But as of today, where are we standing, that is going to be discussed here. I am supposed to put across a case scenario, but we don't generally manage by and large with the non-surgical management, so I don't have an actual patient figure. I'll put up a hypothetical situation here. A patient with a squamous cell carcinoma esophagus, T3N plus, undergone cross protocol, excuse for the spelling mistake, cross protocol, and dysphagia is relieved. Now the patient doesn't want surgery. I'd like to ask the opinion of our esteemed panelists, starting from Madhuri. In such scenario, are we ready to opt for the patient anything else other than surgery?
So in this scenario, the patient, why does the patient doesn't want a surgery? Because we should have had the patient in our discussion group, and he should have been convinced that in a neoadjuvant setting, we are not giving something like definitive dose of quantity. We won't go up to 50 or 50 or 60 like that. We may give up to 40 or 41. So he has residual disease over there. So in such a scenario, we should discuss with him and convince him that he needs surgery as part of his treatment, and without surgery, his outcomes are going to be bad. In spite of that, if he says that I don't want surgery, then I would call up my radiation oncologist and ask him whether they can go up the radiation dose, maybe up to a definitive dose of RT, in spite of the fact that there has been a gap in between. Otherwise, surgery would be the only option for this patient.
So I'll move to the next gentleman here. We did some investigation as well, and we did an endoscopy on this patient, and which showed there is no disease, and CT shows some thickening. So there is reasonable chance to assume that disease has responded well. With this background, patient is an educated patient. He knows about this kind of management which is being practiced in some part of the country. And then he's asking you, so could you help me in not getting a surgery?
Actually, I will first advise for surgery. If patient refuses, then he should be properly counseled regarding the selective surveillance, because I have to find out whether it is CC or not. So I will do what you said, told opposite endoscopy, maybe random biopsy, biting biopsy, then only, and maybe PET scan to see any there is no disease, or if there is a node and disease. So I will advise US FNF from the node also to prove it's a negative clinical response. Then patient to be properly counseled for active surveillance, because it's a very cumbersome procedure, because after completion of CTRT, after 6 to 10 weeks, I will do endoscopy biopsy. Then again 10 to 12 weeks I have to see. Then 3 monthly first year, 4 monthly second year. Then again 6 monthly up to 5 years. Then I will do it. So and every procedure, every time visit, I have to do endoscopy, biopsy, PET scan, and USFNA from lymph nodes.
Yeah, we'll go to that. We'll go to that first next. Now I think there is one issue which I think should be knowing is that she has undergone cross protocol. The cross protocol is not giving the full radiation, which is supposed to be given in CTRT. We'll move to radiation oncologist. So, what is your take on this issue?
Actually, till now there is no level 1 evidence in favor of only definitive chemoradiation for an operable case or this locally advanced cases. Only which are medically inoperable or afferent inoperable patient. In those patients, all the studies of definitive chemoradiotherapy included those patients, not this group of patients. Logically, I can say that 41.4 K is not the optimum dose. At least you should go up to 50.4, 54. But above that, again, the morbidity and mortality increases.
So we'll come to that later. So I like to ask you, I like to reframe the scenario in a different way. The patient came to you, and before planning the radiation itself, the patient is very strongly against surgery. This is squamous cell carcinoma, T3 and plus, middle third of esophagus. The patient, can you do something else so that surgery can be avoided?
Again, if I go for evidence, it's very difficult, but patient, I will definitely first counsel him or her ki go for the standard protocol, that is cross, typically after neoadjuvant chemoradiation and then surgery. But if it is not, when he is not convinced, then I think I will go for at least 50.4 grade with concurrent chemotherapy, and then that response evaluation is very important. That I have to counsel him previously. I can't guarantee that you can avoid the surgery, and then you will compromise the survival, obviously. If still
So I think we'll ask medical oncologists. So do you think that non-surgical management can be practiced in diseases, operable cancers?
So what I believe that the answer cannot be given in a single sentence. So
You can use multiple sentences.
Yes. So first of all, we take all the decisions in my institute in a tumor board. Okay, whether surgical oncologist is there. So in this patient, we started cross protocol. Okay, so that means it was a surgically resectable patient because all the patients in cross trial were surgically resectable patients. First of all. Next, the question is that what was the anatomical location of the tumor? I guess because cross protocol was tried, so because it was below carina. If it was above carina, it was a clear-cut case of chemoradiation, definitive chemoradiation. Whether it's medically operable or inoperable, it does not matter. Above carina. Below carina, of course, the first choice should be surgery. And in resectable cases, you can try, if not, you can try, the data says that you should start with cross protocol. And there are some data coming up, not that good level of evidence, but there are some data coming up that because squamous cell carcinoma are more chemosensitive and radiosensitive, so the PAC-CR rate is higher in squamous cell carcinoma. If you see the subgroup analysis, then in squamous cell carcinoma and cross trial, the PAC-CR rate was as high as 40 to 50%. In adenocarcinoma, it's as low as 20 to 25%. So, and there are some Cochrane data also is there that in squamous cell carcinoma, if you are after chemoradiation, neoadjuvant chemoradiation, you are achieving clinically complete response, and you are doing surgery, probably you are not adding any survival benefit, but you are adding local control rate.
So if you speak like that, you are going to finish my entire presentation, because this is what I will tell you.
Well, to be precise,
yes,
in squamous there is an option for observation as well,
great.
But of course not with this much, this short dose. The dose should be 50 gray, and for adeno, there should not be any option of observation.
Excellent.
I should always, I
reiterate my story. Me and Dr. Madhu used to be practicing regional cancer center, and unfortunately, we have our radiation oncologists who are not so friendly as our radiation oncologists here, and they used to manage everything by radiation. And we, after our training, we started practicing esophageal surgery maybe 15 years back. Till then, every patient used to go for radiation, especially squamous cell carcinoma. And they are supported by this particular trial. The first the evidence comes from the surgeon, which from Kewa et al. He started analyzing the effect of radiation on esophageal cancer, and he found out that the survival at the time in 80s used to be only 10%. 10% people used to survive. Then he started practicing radiation and found out that radiation has improve survival, especially chemoradiation. It could be moved up to 25%. And this particular trial, which is RTOG 8501, which is published in 1997, has proven that the CTRT is associated with a 5-year survival of 27%, which is pretty a good landmark in esophageal cancer surgery, esophageal cancer treatment. And then it is followed by a couple of RCTs, which compared this upfront surgery versus CTRT, and they also found out that the CTRT is as good as surgery, and the only caveat is the regional local recurrences were little high, the need of stents were high, and the treatment-related mortality was high in the surgical arm. So this is completely convincing win situation for radiation oncologists to go ahead with the CTRT. This is followed by another trial which also showed the same results. Again, there was a meta-analysis which favored a surgery arm in the beginning. Then this was followed by another meta-analysis by Cochrane group, which proved that the CTRT is useless. So, ladies and gentlemen, I like to draw your attention to this cross trial, which has shown excellent survival. I think more than 40% 5-year survival, which is a benchmark in esophageal cancer treatment. And especially in squamous cell carcinoma, the survival is very high. I think it reached almost sky. So from there, when we look back to these particular RCTs and even meta-analysis, we are seeing that surgery is not having a better advantage than radiation oncology. Why? So the issue is that in a trial, what happens is at a controlled setting, it is what should be achieved, what is the maximum thing we can achieve. But when you look into meta-analysis or a population data, what we are seeing is what is actually getting achieved in the society. There's a lot of caveats there. The expertise in esophageal surgery, the morbidity, mortality. So in the initial trials, I have shown it can be very high. The mortality can be, there are centers which have mortality up to 22%. My center or your center may not be having that mortality because we are experts. But if you take the mortality of all esophageal surgeries being done in India, it is maybe very high. And the complications are very high. Patients have a lot of issues. Many patients will die. I know a center which I'm not revealing the center's name. The first 10 esophagus cases, they did die. It's a big center. Big center, tertiary level cancer institute. The first 1, 2, 3, 4, 10 patients died. So it's a serious affair. So unless we practice surgical oncology and do better results, that cannot be reproduced by the entire nation. So that's why CTRT is still having a role. So going to this particular evidence, again the Cochrane analysis shows equipoise. So the world is believing that the surgery and radiation are having equal survival figures. Radiation is having less mortality, and even though there is local recurrence is high. So again in this particular one of the RCTs, they did quality of life also, which I feel many of the patients who were radiated previously and cured, they come back to me with a lot of dysphagia. So at that time, I do an endoscopy. I am unable to say that it's a disease or it is fibrosis or disease, and it's a mess. And I see many patients could not eat properly. But this particular trial has shown that the quality of life is not bad in CTRT. So CTRT is.
I think for the dose, because now the dose is less. And we used to give more dose, when only after dose.
Yes, ma'am. And we are going to discuss about the non-operative management in a detailed way. So we'll be coming about dose and etc. later on. But what I feel that in order to be, if you are giving CTRT, it has to be 60 gray or more than that. It cannot be 40.1 gray.
Now it's 50.4.
50.
It will give RTC.
Yeah, there are centers being up to 60. So how do you think, ma'am, the reduction in dose helped? You said dose is less.
Yeah, now it's less because now it's say that if you are giving chemotherapy, then your dose should come down to at least 54, not beyond that.
Okay.
But when we gave RT, the dose was nearly 65. So the dose has come down now with chemotherapy. Chemotherapy is added.
We will discuss that later. So that is a background of information. Again, this is one of the very recently 2020 published study which shows pooled 5-year survival 68% for wait and watch policy. So I think whether we like it or not, wait and watch is going to come. It is going to revisit. It's a reality rectum. It is going to be a fact in esophagus as well. So with this background in mind, so well, I'd like to ask you. Suppose you decide on doing a non-operative management with the full dose. We decided on it, and you gave the entire 54 gray. CTRT is given, and patient wants a non-operative management. You did it. Then how are you going to follow up the patient? We will start from here. Kedul.
There is no doubt we have to do PET CT scan and upper GI square biopsy is one thing. We can add endoscopic ultrasonography if facility is available, and very close surveillance is very important. And there might be some role of diffusion weighted MRI as some studies are going on. So we can follow up with these modalities if facilities are available. Close with 3 months or every 3 months like that in initial.
So again, I like to ask the surgeons again. Are you convinced by the trials, the meta-analysis that such patient CTRT can be given? Are you okay?
Recent evidence don't have a level 1 evidence support. We can give a definitive CTRT because the what the study you alluded to, that was I think a Chinese study.
I'm sure it's only studies. It's a Cochrane analysis.
Yes, yes. So
there are 2 RCTs.
yes, sir. Even though the evidence is
only one meta-analysis support a surgery.
most of the studies do say that surgery has definitely an upper hand over CTRT. Sir.
Anybody, even ma'am, would you like to agree with this gentleman?
Till now, I am to some extent agreed with him, but 2 bigger studies are ongoing. This was trend.
No, that's it now. It's ongoing, it may change. After some time you may win over him, but now.
If I am convinced that it's fine, but still it's indicating like that we can avoid surgery, but obviously with proper active surveillance, and also that clinical response evaluation after the chemoradiation is very, very important.
We are doing everything, but can we go ahead with a CTRT protocol, avoiding surgery, and so that we can look much for observation. Is it possible or not?
Is it possible? It is possible.
Sir, a short answer.
I
Don't go
told
long.
that for squamous histology, yes, we can observe the patient if adequate dose of RT and chemotherapy is given.
But sir is saying there is no evidence, level 1 evidence.
No, there is no such RCT, I am telling, but there are.
And I showed 2 RCTs.
Yes, but the level of evidence was not that strong, and the design was not that in that way. But for adeno, I will prefer to refer back the patient to surgeons.
Agreed. Madhu, would you like to contribute?
So we should make clear that we are discussing about squamous cell carcinomas. In squamous cell carcinomas, if we go by evidence, as you said, we had 2 randomized controlled trials, the German trial, the French trial, that showed that if you go by definitive CTRT, you can have same survival. But the only problem with those 2 trials were that the dysphagia-free survival and the lockdown recurrence was much higher. So that is why we still add on surgery at some point of time. So in a definitive CTRT setting, there is a role for wait and watch policy. But now the question is, in a neoadjuvant CTRT protocol, do you have an option of wait and watch policy? So now we are coming to lesser doses. Across protocol, we are seeing that when you operate, we have PCR rates of about 15 to 20%. So can we pick up those patients and then keep them on follow-up? That's what the pre-SANO trial, which set clear guidelines on how these patients should be.
I'll come to pre-SANO. So Shekhar, the issue is that they have to be convinced about non-operative management. Then they can only go for further follow-up only after that.
After neoadjuvant CTRT protocol, we don't have evidence for kidney unless we have data from the SANO.
Yes.
So pre-SANO has now set the goals to how
Yeah, I'll
to
come to
follow.
pre-SANO later. Fine. Any other opinion? We'll call for vote.
After cross trial, we can go ahead with wait and watch follow-up protocol.
Okay.
Because patient should receive different.
So you're supporting follow-up?
Yeah.
Okay. You have pharmacy company supporting follow-up.
Question to my radiation oncologist colleague. Are you comfortable with after cross 41.4 and after 4 to 6 years assess the response whether if it is a non-CCR? So are you comfortable with back it up your radiotherapy with another some more fraction? After 6 weeks.
After 6 weeks, adding there is, it's not recommended, or I don't think any protocol is there or any study is there. If we plan, we have to plan upfront the full dose of 50.4 with chemotherapy.
Ma'am, I think this particular trial, they have two arms. They recruited after the cross dose. They recruited one arm, went on to get surgery. The second arm went on to get continued radiation. This happens. So I think many times what put us into trouble is I work in institute, it's a government institute, me and Dr. Madhu. And what happens is, we agree for cross protocol and patient completed cross protocol, then there are some logical reason or some unfitness for the patient, we don't operate it. Then we have fuming radiation oncologists looking at us, asking, I don't know, we should have told this before.
Yes.
It's a difficult situation.
Yes.
So how do you tackle that situation, ma'am? You have cross, you are not, you have done cross, you are scheduled for surgery. So how are you going to continue with the surgery, radiation if you are not planning surgery?
If you have to wait for 6 weeks, then you cannot give RT again because substantial dose has to be given.
That's true.
So that cannot be given. So in that case, we have to go for chemotherapy or something like that. RT is not indicated.
Yes, sir.
See, whenever you plan any protocol, either cross or anything, what is the completion rate? Means if you are not able to do surgery, then the treatment is not, planning is not appropriate.
That's true.
In our presentation also, that 30% of the patients don't do. They get across, after that when there is a good response, they are able to eat, they don't go for surgery. And then across, we are
Phase.
41 grade. So then, whatever is possible in a clinical trial setting is not possible in practical setting, especially in the Indian country. So that is the reason why CTRT is going to stay. And either you can plan for surgery upfront, followed by adjuvant radiation if required, or CTRT, because that is practically possible in maybe 70-80% of the patients who will complete. If you are not able to complete the treatment in only 41 days and not doing surgery, then the outcome is not that great. I think then.
Sir, but I like to ask you, in cross also you have nearly 29% of PCR. And so what will happen to those patients? It's a good PCR rate. Those patients shouldn't recur ideally.
This PCR rate is at 12 weeks, 16 weeks. If we follow at 24 weeks or 28 weeks, then there will be recurrence and
It is coming back.
Yeah, that is bound to come back.
That's
Because
true.
the dose
And
is
then
less.
1 year follow-up for CTRT and 1 year follow-up for 41.4 grade and cross protocol. There 41 grade may be more local recurrences than CTRT. So in Indian setting, we need to
Balance everything, yeah.
practical what is possible in Western population may not be already in clinical trial setting. We should see that whether it is possible.
That's why we do not usually give, when we assess the patient, if we feel that this patient is likely, if there is a good subjective response, then this patient will not complete the surgery. So that's why we do not usually give the cross dose. We usually give 50 gray.
Okay.
50 gray.
So when are you assessing the patient? When will you assess the patient?
Yeah.
When will you assess the patient?
We advise the patient for surgery.
Okay.
After 6 weeks, but if the patient does not turn up, then at least we are happy that 50 gram, less dose.
But there is going to be a delay in between. You are
Yeah,
calling back the
yeah.
patient. Is it okay?
Delay 6 weeks.
It's not okay. It's not okay. So we have to plan it, at the very front what we want to give.
So is there a way you can plan at the end of your radiation, the last day of your radiation and plan and
You
proceed?
cannot assess the
Is it
response
okay?
before 6 weeks.
Assessment
You
is
cannot assess.
even after a month.
Yeah, that's a problem.
Yeah,
That's
so
the problem.
that
A month is lost.
So my thing is, when the patient is not coming for surgery and leaving the radiation oncologist and taking CTRT, you are thinking that he will come for 4 to 6 weeks follow-up, then 10 weeks follow-up, rapid follow-up, robust follow-up with all the imaging modalities and endoscopy. So I think in Indian scenario, it's very difficult to counsel the patient for strict follow-up.
Yeah, I think we have only 10 minutes left. I have to take to next level. So I agree that there is a role for non-operative management for the cancer carcinoma.
Madam, correct me if I'm wrong. You cannot change from a neoadjuvant protocol to a definitive CTRT protocol midway between a process. You have to take that call before you decide on what you are going to do. Because the cross field is different from the definitive CTRT field that was planned in the German and the French trial. So midway, you cannot say that this patient may not go for surgery and you have to change the protocol to definitive. That call has to be taken upfront.
Yes.
I agree. I think that most people are arguing for it, but that is practically little difficult at times. So next, I would like to ask some questions in the next 10 minutes. So anyway, we are following the rectal cancer management. The rectal cancer management, what happens is, one thing which joined the armamentarium is more chemotherapy, consolidation chemotherapy. Likewise, in esophagus, can you do little more something, little more, maybe little more RT, little more chemotherapy, or little changing chemotherapy, or target treatment, or immunotherapy, so that this non-surgical management is backed up with some more systemic treatment. Is it okay? So first question is RT. There is a trial giving more RT and versus conventional RT. Madam has partially answered. RT they are reducing now. So what is your opinion?
Madam already told with increasing dose of RT, it's already shown there is not much gain in any way, and only increasing the morbidity and to some extent mortality also. So adding radiation,
you can't radiate more to 64 and with more advantage. So RT is out. So we'll go to the next thing. Can we give more chemo, one course of consolidation chemo, and see whether it increases the cure? Is it possible?
Already in interview trial, we are giving cisplatin 5-FU concurrently with our radiation 2 cycles.
Yes.
And after the radiation is over, another 2
Then
cycles.
over and over, is there a role
In that
for
trial,
consolidation?
already after chemoradiation in that trial, already 2 cycles cisplatin 5-FU were given after the completion of chemoradiation. In that trial, that was the design.
Question is, before chemotherapy, before surgery, is there a role for, before RT, is there a role for giving one more cycle of chemotherapy?
You mean, sir, neoadjuvant? Neoadjuvant data is not that strong.
Yeah, there's one study which showed some advantage. I think it's a Chinese study. We will be little doubtful believing it. But I think nowadays more and more Chinese studies are coming with a lot of acceptance. So again, it's not a first level evidence. Then the next question is, can we change chemotherapy and get some more results?
So still in definitive chemoradiation, cis-5-FU is the standard.
Okay. You can't change, there are some evidence saying that some people tried irinotecan also, and oxaliplatin also, and paclitaxel also to get some more results.
But the strongest data is with cisplatin and 5-FU.
It's not. Okay.
And that is given 2 cycles with radiation and 2 cycles after the radiation is over.
Yeah. Great. And I think unfortunately now most of the discussion is of non-operative and not much role for surgeons. We will concentrate on our friends there as well as our medical oncologist, radiation here. Target treatment, cetuximab, statuximab, COX-2 inhibitors, any role? No role. Anybody? You can ask anything. Because what we feel in many, I like in the panel discussion which occurred earlier, in colorectal liver metastasis, they are saying that more and more use of target therapy, newer and newer chemotherapy is going to reduce the need for surgery, extended surgery. Anything can be practiced in esophagus?
So I am not expert, but as seen in checkmate trial, adjuvant immunotherapy, I don't know whether neoadjuvant immunotherapy with CTRT might have some role in future.
Sir, medical oncologist, any role for immunotherapy in future? Are we going to do immunotherapy? That's what we are fearing. Surgeons are fearing that.
Maybe it's coming up. It has come up in lung also. For lung also, neoadjuvant nivolumab has come up. But still, our practice has not changed for esophagus and stomach. We have not shifted to adjuvant immunotherapy till now.
Great. So I think the bottom line is the CTRT with the conventional CTRT protocols are the best enough. Nothing can add on it. Again, I think that any CTRT protocol or observation management should be backed up by a salvage protocol, which should be there in rectal cancer. It may not be so easy in esophageal cancer. I'll come to that topic next. So we can again, there are a lot of modalities. I don't think nothing is foolproof. We can do symptoms. We can ask the patient when we start dysphagia. We can investigate. We can image endoscopy, and especially ultrasound with endoscopic ultrasound, PET scanner, etc. useful. And my next question is how to this pre-Sano trial, which Dr. Mathu mentioned about. Mathu, would you like to say something about the pre-Sano trial?
I think after a neoadjuvant protocol, if you think that the patient is not going for surgery, we should be sticking on to what the guidelines of pre-Sano have set up to keep the patient on intensive surveillance. Where PET scan has not been found to be very good enough. So the endoscopic ultrasound, biopsy, and a good CT scan or MR would be the ideal imaging modalities to be decided on based on which we can keep the patient follow-up on.
Yeah, but the issue with the trial was it has shown disease, it has good specificity. We diagnose disease, but ruling out disease, the sensitivity is less.
Yeah, sensitive, but still they have come up with three imaging investigation modalities based on which you can say that probably this patient has got PCR and you can keep the patient wait and watch policy. So now we have to wait for the Sano trial to come out with what is the survival data of those kind of patients who have been kept on follow-up based on these findings. So pre-Sano's just set up a template to decide on which are the patients who you would select to keep on wait and watch policy.
Okay, and we'll come to the hot topic, salvage surgery. So again, patient went for this non-operative management, came somebody did a recurrence, and how comfortable are surgeons guys are doing a salvage surgery, and what is your take on this issue?
So salvage surgery, usually it is high morbidity and a lot of complications because when the recurrence will occur, most probably many times, if patient is not in strict follow-up, then there may be unresectable type of recurrence may occur. But so if resectable also, patient may lead to high complications of anatomy leaks, strictures like that. Because
So anything, Ketu?
Sir, salvage surgery.
All surgeons have to speak about salvage surgery.
Salvage surgery is.
It's only one can speak.
It's not like it's not. It has some complication definitely. So whether this complication is statistically significant or not, that we don't know. That Sano trial will tell this thing. We have some idea about that complication in salvage surgery from Sano initial data. But in general, if it is an adeno, then recurrence will be more in a systemic. We expect this. And if it is a squamous cell, the recurrence usually comes in a locoregional. So whatever be the histology, salvage surgery is to be, even what the data says, it should be treated as an individual basis. How the recurrence is, pattern of the recurrence, length of the disease comes out. So it should be individualized and it will take a call after the evaluation.
When you do a salvage surgery, how it is different from a primary surgery? So what is the changes you do and what's the morbidity you expect differently?
Actually, sir, in our real world scenario at GCRI, 50% of the patient only come for surgery post CTRT, and rest may have progressed or metastasized or
after cross?
45, we give 45.
Okay.
And 10 to 15% patients come for surgery after 6 months or 1 year. And then the scenario is changed. They have.
It's almost a salvage.
It is salvage surgery now, and R plus resection is high. Inoperability rate is high, and exactly pulmonary complications and leak rate, all these are higher when we do salvage.
How high? It is very, very high or?
Sir, we have no data, but we are feeling that we have difficulties operating salvage surgery.
And what about lung morbidity? Is it high?
Yes, sir, it is also high.
Okay. Sir, what do you like to say?
Sir, as far as the studies, I practically don't have any experience as surgery, but what the data says, there is a publication in JCO 2015, sir. What they say, the survival is not different, but definitely the leak rates are much higher, pulmonary complications are higher, sir. And there is some evidence such as a patient having complication post-operatively that does have a bearing on his survival. So I would definitely contemplate before operating on this patient, but then again, salvage surgery is always better than doing nothing on the patient.
Sir, what do you like?
From the practical experiences during my training, when the COVID occurred in 2020, pre-COVID all the patients were taken in CTRT. I was with Ketul sir at that time, and after 6 weeks, for around 3 months, the OT was closed because of COVID, and then we had to operate many of these cases long after CTRT. That time it was technically very difficult. The problem is not only with the post-operative complication, also technically fibrosis. There is many of the cases have it's a dense adhesion with the trachea or bronchus. And it was very difficult intraoperative also pre-operative, post-operative complications were there, but intraoperative it took longer time, more blood loss and more difficult dissection. Sometimes some small tracheal or bronchial injuries or fistulas happened. So this was from during my training, it was a practical experience which how difficult can be those if it can be more longer waiting time.
Yeah, I think salvage has very high mortality and morbidity, and it's difficult. I think we are closing now. So usually I think the discussion and consensus now for patients with clinically resectable adenocarcinoma, we suggest surgery should be there. And having non-operative management is an option for SCC who has an endoscopic complete response, balancing risk of surgical mortality versus improved local control. And regardless of histology, definitely CTRT is a reasonable approach for patients who are not surgical candidates. So even adenocarcinoma can be undergone CTRT, which is not surgical. And further additional treatment like target therapy and immunotherapy are being investigated. And identifying recurrence in post-CTRT esophagus is still a challenge. Thank you, Raj.
Just a question, sir. Is anyone practicing any form of chemotherapy after cross if the patient is not willing for surgery or not fit for surgery? Any form of chemotherapy after cross, patient is not willing for surgery or not fit for surgery? Opting for surgery. Anyone practicing any chemotherapy after?
Last time, medical knowledge.
After a cross, if the patient is not going for surgery and clinically complete response, I am not practicing chemotherapy in such patient. Just observe.
I think it's a...
Yes.
Thank you. Shake up.
Thank you, sir.
Last comments.
I think the results of RTOG 0246 will be interesting. Where if the dosage is definitive chemoradiation for all patients, and then a decision based on assessment, I think that is likely to be the future, but that depends on the results of RTOG 0246.
Yeah, 0246 is going to come.
Thank you, Dr. Chandra,
Thank you.
for
Thank
a
you.
wonderful panel and a very interesting discussion, which is, I think, next gen discussion.
Thank you, Dr. Chandraman sir, for an excellent discussion on neoadjuvant chemoradiation cerebral cancers.